Thank you so much. It's great to be here. It's just a joy to be part of this celebration of this center. My career in public health began here in this center, and it is just great to continue to be a part of it. So much of where I have been and where I'm going was directly influenced by Carol. So in 10 minutes, I'm going to talk about racial disparities in health, which is challenging. And because there are so many other talks touching on so many important parts of racial disparities and health disparities broadly, including in this section, they're not necessarily touching on disparities specifically, but if we think about the placenta or the microbiome or stress, any one of those we could think of as important players in racial disparities and understanding what's happening in inequitable outcomes. And because those are happening and those different storylines are coming together in different ways, I'm going to take a step back and talk about two problems that I feel like we sometimes grapple with and we don't always grapple with enough in how we talk about studying racial disparities in maternal child health. And it's the problem of ubiquity and the stickiness of structure, which is just wonderfully opaque and doesn't mean anything right now. All right, so I'm going to talk a little bit about preterm birth because I'm really interested in where do these little tiny babies come from. And I'm going to start off with this idea of the problem of ubiquity, which is the notion like the fish can't comment on the state of the water in which it is. Sometimes causes that are really important are made invisible by their commonness, by the fact that we can't see them because they are so ubiquitous. And I think this is a challenge that we face often in many settings, but particularly when we're thinking about social disparities in health. So this is the distribution of singleton births, live singleton births by gestational weeks in the United States. And we can see that most births are term, which is good. They're in that healthy category to the right. There are some births that are preterm. They're to the left of that green line, 37 weeks, some that are very preterm birth. And one of the things we do as researchers, as epidemiologists, is we try to understand what are the causes of this preterm birth. Why does this happen? And the approach we take is what Jeff Rose, the approach we often take is what Jeff Rose called finding the causes of cases, which is to say, what are the risk factors? What are the things that predict being in one of those buckets, being in the term bucket, or the preterm or the very preterm bucket. And that research has been fruitful in many ways. We've found things like infection and stress and smoking and genetics as contributors to preterm birth. So thinking about why you're in the right-hand side of that distribution versus the left-hand is useful. But another piece that we don't always ask is what causes the shift of an entire population's distribution. So here what we have is the distribution of gestational age for black women in the black line and for white women in the red line. There still is a low-risk group or a group that has good outcomes in term, and there's a higher risk group or a group that's preterm or very preterm to the left for both. But one thing we see is that the entire distribution for black women is shifted to the left. And the questions, the approach that we take to finding the risk factors in the previous slide don't work the same here, because when we're only looking to say who's in the high or the low end of the distribution, we can find that, but that approach doesn't tell us what's causing an entire population to shift to the left. But it does lead us to ask about other questions. What are features or factors that may be ubiquitous to a population that is not present in another population? Things like stress, or racism, or segregation, or opportunity structures. So how can we think about disparities arising like that? So I'm going to use a different example now, infant mortality, which of course is closely related to preterm birth. And I'm going to take this historical perspective to try to tease out this idea of what does it mean to have a population driver of risk or rate. So this is the history of infant mortality in the United States for black and white women. At the turn of the 20th century in 1900, infant mortality was astoundingly high, and it dropped substantially across the 20th century. This is actually one of the CDC's top 10 greatest hits at the end of the 20th century. They had an MMWR about the 10 greatest public health successes, and one of them was a reduction in infant mortality. When we look at racial disparities, we can look at the gap between black and white in two ways. The yellowish line is the rate difference, so the rate in blacks minus the rate in whites. And the storyline that we get there is we've made progress there as well. The racial disparity has declined. But if we look at that blue line, and the axis for that is on the right-hand side, that's the black-white ratio. So it's the relative gap between black and white. And what I find astounding about that, if you look at that, for 100 years, the black-white ratio has been between about 1.7 and 2.1. Given what we know about the changes of the drivers of infant mortality across the century, that it used to be all infectious and then it changed to the role of the relative importance of prematurity or congenital anomalies or injuries as we've gone along. Given how much change there's been, it's astounding that we have this consistency in this relative ratio. So what does that mean? One way of thinking about this is this idea of the stickiness of structure, so that the way in which we're organized doesn't just change the risk of a population at a point in time, but it reproduces imbalances in opportunity and risk across generations. Even as the cause of death changes, that the same stratification, the same structures reproduce inequality. So to make this make a little more sense, if there was a disease for which there was no prevention, for the most part when we have diseases like that, we actually don't see a disparity. We see that they're pretty evenly distributed because we don't know what caused it, and it happens sometimes. There's some brain cancers where we just don't see any disparity. We don't have a prevention for it. But when we have technology, knowledge or pharmaceutical or surgical technology, then we begin to see disparities emerge because the diffusion of that technology is not always equal. The diffusion of that technology is patterned by people who have political, social, material capital. So one thing that can happen is we'll see rates decline because the technology improved health, but relative rate ratios either be flat or increase because one group declines faster than the other. Maybe the technology eventually diffuses, but it goes slower. So we tried to take this back to our story about infant mortality, and we looked at cause-specific infant mortality. We only have cause-specific infant mortality from 1920 on. What I'm plotting here is the black-white rate ratio of infant mortality from gastrointestinal diseases. And what we see is that in 1920, it was almost 1, so basically there was very little black-white difference in death from gastrointestinal disease. But then through the mid part of the century, this rapid increase to a rate ratio around 7-fold difference in gastrointestinal disease. And this happened because the risk of death for whites declined much faster during that period. The other thing that happened then is the evolution of municipal clean water supplies, so the systematization of this public health innovation. Cutler and Miller have this really nice paper about how inequitable the rollout of municipal water supplies were. That, not surprisingly, they were available earlier to richer and whiter neighborhoods, and they were available later to poorer neighborhoods of color. So we have this instance where an innovation occurred, it improved health, but it improved some health earlier, and so we get this increase in disparity and then a decrease. So another important cause of infant mortality is prematurity. Again, early on, there was very little black-white gap in cause-specific death from prematurity. But we see, again, a little later, mid-century, this increase. And what happened during that period was the evolution of neonatal care. The services, the amazing technologies that really allowed the increase in survival of tiny, tiny babies. And while we think of a hospital like Grady now as providing just top state-of-the-art care for a medically underserved community, in the beginning it wasn't like that. Those initial services were not available in poor communities first. They were available in wealthier communities first, to insured patients. So as this innovation rolled out, it was available to some populations. They improved faster, and then eventually that progress, that technology diffused. Just one last example, SIDS is not a leading driver of infant mortality, but it's important. The pattern here is similar. It's a little more subtle. We only started measuring SIDS as a cause of death in 1980, or I only have data on that. And we see a similar pattern where there was a smaller disparity that increased, and it increased after the Back to Sleep campaign began. And some people who've looked at the history of the Back to Sleep campaign have noted that it didn't, that the public health messaging to the black community was maybe not as culturally competent as it could have been, and so it wasn't as effective early on. And eventually that has improved, but maybe that technological innovation was knowledge, it was information, it wasn't about a new surfactant or a new NICU. So this idea that thinking about disparities may be important, an important part of thinking about disparities is the identifying the risk factors, understanding these mechanisms, understanding these etiologies. But another important part is understanding how do we reproduce, how are these disparities reproduced through time, even as the underlying causes change. And one challenge that we have is thinking about this problem of ubiquity. How do we observe exposures that may be so common as to be invisible? So things like racism, and the stickiness of structure. How do we observe the way in which social arrangements differentially provide access or allocation of opportunities, including new public health innovations? That's all I got.